Good morning, everyone. Hope I'm audible to all peoples. Yes. Okay. A huge welcome to everyone wherever you are joining us from around the globe. And it's my distinct honor to welcome you all to this webinar today. And we are privileged to welcome and have with us a true luminary in the field of anesthesia, Mr. Kishore Ramalingam, who brings us with him her 25 years of experience as an anesthesia assistant and 11 years of a teaching experience within. And presently, he is an anesthesia associate in St. Michael's Hospital, Unity Health, Toronto, Canada. His impressive credentials, including BSc, RRT, CCAA, MBA, and FCSRT, speaks about as a volume about his dedication and his expertise around various areas of healthcare. Today, he will be sharing his valuable insights in the topic of immense relevance and critical importance in modern healthcare in the topic of the role of anesthesia professionals a way forward. As we know, the healthcare landscapes are continuously evolving rapidly, driven by technological advancements and shifting patients' needs. Of course, the role of anesthesia professionals is also expanding beyond the operating room. So today we are eager to know the perspective of his view on how the anesthesia professionals not only just adapting but actually shaping the future of modern medicine and ensuring patient safety, outcomes, and overall perioperative excellence. Now, without further ado, I welcome you all to hear the speech of our speaker. Welcome you all once again. Thank you. Thank you, sir.
Over to me. Okay. Hi. Good morning, everyone. It's a late night for me here, although it's a shiny morning in Chennai, in India, and good day, everyone around the world, wherever you're joining. Happy to be on screen and to present the evolving and rising responsibilities we as anesthesia providers have and will get in future. Although I'm missing in person, I'll try to keep the talk as conversational as possible rather than just presenting. We are here on National Day, as I got the information from Jagdish. We will be talking about what we can think about and what we can plan and move forward taking the anesthesia providers as a professional in the future. Before talking about what the future holds, if you all allow, let me introduce myself a little bit so that you can know the past, present, and future, what we can get into. I just want to hear from one of the faculty that I'm audible there. If one of you can voice it out for me rather than me just talking and not knowing that I'm audible, please, before moving to the next slide. Ms. Vinodini, if you may say it out.
So yes, sir.
Okay, great. Thank you. Thanks for the feedback. Okay, moving on. I actually have only 6 slides, so the one is already gone. So the remaining is 5 slides. So I won't be taking a lot of time, but through those slides, I'll be giving some information which might go around 40-45 minutes if that time permits. If the time is limited, please do let me know. I can shorten it out, and then I will save some minutes for questions later. So let's go into the introduction. As I just mentioned, I will introduce myself. And before I talk about myself, I will be addressing all the anesthesia providers. Nevertheless, it doesn't have to be a physician. It doesn't have to be a respiratory therapist or anesthesia technologist or a respiratory therapist, respiratory technicians, whatever the roles are. All we call it as an anesthesia care team. So here in North America, we entitle them as anesthesia care team. The most prominent care team members are the staff anesthesia and the anesthesia assistants, which currently I'm in that role. So I address anesthesia providers as anesthesia assistants if you don't get confused about it. Okay. Every role which I've been throughout my 25 years plus. It's been a learning journey throughout my career. Um, Obviously, I started my career in India. I did my BSc Allied Health Science, specialized in anesthesia technology from Sri Ramachandra Medical College. I was the first batch, the first ever batch in India to actually have that. I was fortunate enough to do that and um, play a role as pioneer at the time. Then I nourished my career in Middle East for around 11 years, and then I ended out in North America, in Canada. So what I'm trying to say here is when you surrender your ego, whoever you are, whatever you are, and put yourself ground to earth and open to learning, um, sky is the limit. So never surrender yourself to the limit of the knowledge that you currently have. Okay, I'm not the first person to say this. Your parents might have said that. Your peers might have said that. Your teachers, mentors might have said that. So I'm not the first, and I'm not going to be the last. So saying that, let me talk about where and how I started. So I started my career as a junior anesthesia technologist at Ramachandra Medical College Hospital. Right after my internship, actually, during the completion of internship, I was fortunate enough to be picked up to work, join as staff in the hospital. And shortly after joining, I took the role as in charge of equipments, the anesthesia equipments like the gas machines, monitors through the hospital. But in few months, probably maybe 8, 9 months, like many young person, I also was not sure about the future. I was like, I also reeled into computers because the time I passed out was 1999. 99 was the year where a lot of computer gadgets were having hiccups saying 2K, there will be a problem. I don't know how many of you know about it, but if people who are 25 plus obviously know, 30 plus might know about it, or might have heard about 2K problems. So I also had that in my mind, and then left the job and joined the MCA, completing a science degree, joined an MCA. It was weird, but I got into a sports scholarship. I was playing cricket, so I got into MCA at SSN College. You might have heard about it. It's in Kelambakam, where I was guaranteed a job right after the completion in the campus itself. Funny enough, I tried to stick around there. 1 year I might have completed, just wrote the exam, or didn't even write the exam. I think I dropped out. I could not continue in computers. Went back to anesthesia actually, went to Middle East. It was more of an assist role, like how we do in India. I worked for 12 years there, but was not entirely happy going forward because it was stagnant role. I tried to do. I was taking over scientific sessions there. I was teaching the peers, teaching the juniors, but I was not happy because I was not able to progress in my skills and knowledge. So I moved to Canada, but it was a tough few years because in Canada everything is regulated. So I could not get into the same role without doing education. So I had to do another 6 years of education here. I did respiratory therapy, which is a pathway to work as anesthesia professionals. So I had to do that program, and then completion with the college exam, and then we have a national board exam. It was one of the toughest exams. Passed out and started my career as a registered respiratory therapist, which is a very highly recognized a job role in Canada because respiratory therapists are the one who are called for airways. Um, no matter where it is, emerge, OR maybe not because anesthesia staff is there. Emerge, ICU, wards, floors, anywhere there will be a stat call. Stat call means emergency call. They call us, they page us for intubations. So we take care of airway, we take care of heart lines, blood gases, obviously ventilation, because that's like bloodline, lifeline of a respiratory therapist. So we take care of intubated patients, tracheostomy patients, emergency patients coming with breathing issues, status, asthmatic, CHF, name it. So we'll be there. So worked for couple of years, and then I got into a teaching role again, which I always want to do. So I moved on to a teaching role as a consultant with Brago gas machine. I don't know whether you guys have been exposed to different anesthesia gas machines. There is one called Brager Zeus gas machine, which is the German company. They actually have the bells and whistles in that. So there's another gas company called GE, most widely used, which is a little cheaper. So, but where I worked as a Brager, as a consultant, I had the opportunity to go throughout entire Canada, east to west. In India, we call north to south, because it's more of a vertical country. But in Canada, it's east to west. It's more of a horizontal line. I was able to travel to almost every single hospital in Canada, teaching anesthesiologists how to use the anesthesia gas machine safely and efficiently. Because it is a new software-oriented new platform for anesthesia providers. I was able to excel in it. Why I was able to do the better job in that is because of exposure again. I used the gas machine in Middle East, so I was able to have the qualification to teach. I was able to know the gas machine in and out, and as a clinician, I was able to understand how to explain it because ventilation, back again as a respiratory therapist, is bread and butter for us. Also worked in hospitals to keep the clinical skills. Worked as an OR RT. OR in India we call as OT. Here we call as OR, operating rooms. So also worked as an OR RT, very similar role as anesthesia technologist, but anesthesia technologists assist but ORRTs do intubations, obviously. When staff gives medication, ORRTs intubates. We put art lines. We do the bronchs. So those are all the key roles of ORRT. But I don't want to stop there. I want to get into a licensing authority where I can provide anesthesia without shadowing me. So I moved on to study a postgrad anesthesia assistant program where you can actually learn to be independent and make decisions, clinical decisions I'm talking about. So it is also a tough program, but it was not tough for me because of the background I came from. I had bachelor's in allied health science in anesthesia technology in India, right? So it was kind of a cakewalk for me. So finished it, completed another national board exam to work as an AA. So we call here as AA, anesthesia assistant. So if you see my credentials, CCAA is a Certified Clinical Anesthesia Assistant, where I started the role as AA after completion, which I dreamt of before I moved to Canada. So overall, 25 years plus of clinical expertise in anesthesia, respiratory, and in teaching. But I never forget about my dedication to patient care, either teaching or being a clinician. If you're always willing to advance your skills and knowledge, your career will uplift with that. There's no doubt in that, right? It's not about just the skills and knowledge, but you need to have that commitment and dedication, which is more important. I think enough bragging about myself. Maybe I'll just say about the skills and certifications that can add your value. So obviously, I have to be a provider for basic life support, advanced cardiac life support, and neonatal resuscitation program. So NRP is for the neonates, BLS and ACLS for adults, PALS is for kids, pediatric advanced life support, which is not mandatory here, but I had it, but I couldn't keep credentialing myself because it was not needed for me. Also, because of interest in teaching, I took a course to become an instructor for BLS. So I'm a certified registered BLS, Basic Life Support Instructor from Heart and Stroke Canada. Anyone who gets a certificate from me through Heart and Stroke Canada, obviously, can provide a CPR and use an AED and do the basic first aid and airway throughout the world. So Heart and Stroke Canada and American Heart Association are recognized throughout the world. So you have to be proficient in computers, obviously, because everything is computerized now. For example, when I'm saying about computer skills, you not only the Office or Excel stuff, you need to know how to document it, right? So clinical documentations are more involved in computers nowadays. At least in North America, everything is computerized. Where I work now, we have a software called Epic. Everything is click, 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 click. So I don't have to keep writing an essay. Obviously, if I intubate, I write the note. which is all presets. I just click and I made a macro for that, so that I put a 7.0 easy intubation, click it, everything comes in. The depth, the grade, difficulty, everything all set. So you have to be proficient in computers to keep yourself up to the level of actually the current level. In the future, we are, get to know how much we have to certify ourselves. So as the future proceeds, we have to upgrade ourselves. Many 60s and 65 years old have, voluntarily retired because of this program. It was funny when it launched. Many could not cope up because it's too much of computer information. Obviously, you should have management skills, communication skill. Without communication skill, you cannot get by what you want to do. You will not be able to do a closed loop communication with staff, nurse, whoever it can be, even with the patient, right? So you should have a strong communication skill. If you are a senior, if you're an instructor, tutor, professor, you should have some leadership skill, right? You can't just come and, say what you think is right, rather than the person in front of you who's a student, whether he or she is getting the information from you, right? So that is very important key role. I kind of, felt bad that that is not covered in college studies. You are forced to learn this while you work, while you progress in career. I wish this is done in India earlier, but in North America, they focus that on very much in the college and university work itself by doing a lot of presentations, posters. You have to be a better communicating person. So I wish that is coming up in India, more in college while students are still a student. Okay. Moving on to the next slide. I think this is all about myself. Enough yapping about myself. I'll talk about the role that is getting evolved as anesthesia assistants or anesthesia provider. Don't get me wrong when I'm saying anesthesia assistants. So I'm just putting myself in the shoe there, saying about how the role can be evolved and how it actually evolved, right? So we never are never been the same as what we do a few decades ago, right? It's growing and it's still growing. Every role in a job, you say, can be evolved, right? If the individual is steered into that, right? If they steered into that in a positive mindset and ready to explore, you know, it will keep on evolving and it will keep on getting better, right? A role or anesthesia technologist is a role is no different. And also in Canada and North America, believe it or not, they started the role as manifold technician, right? So the manifold technician, obviously, you might be knowing who they are, right? So they are the one who takes care of cylinders connecting to a central place where they can they make sure that the gases like oxygen or medical air or nitrous oxide, whatever the gas be, are sent to the operating room, ICU, floors, right? So they are the one who actually hooks up the cylinders and making sure Even before that, long back, they actually were bringing the portable cylinders like E-size, H-size cylinders, connecting it on the floor, and then restocking it. That's how they started, right? So it's basic um, labor job. That's how they started, right? You don't need to know any information. You just need to know how to connect it safely. That's about it. You might be getting a day or two or a week of training for that, and that's about it. But they didn't stop there, right? So they became a respiratory technician. So in India, a term is said as respiratory. Here we call it respiratory. So I'm keep saying the respiratory technician. Respiratory technicians just by studying the apparatus, right? So they started evolving by studying the medical apparatus. Then they took care of the ventilators and the gas machines, meaning anesthesia machines, right? So they were able to identify the problems, troubleshoot, and be a background professionals to help the OR run without downtime, right? So they became a vital part, being a technician. And then they didn't stop there, right? So they evolved into being a medical professionals, right? Studying medical sciences, obviously anatomy, physiology, pharmacology, you name it, you know it. We were already studying by now. So they evolved into becoming a respiratory therapist, right? So respiratory therapists been there for decades now. They are again a well-recognized professional who specializes in airway, breathing, and ventilation. So they work in emerge, they work in ICU. I'm a respiratory therapist, right? So they work in CCU, CICU, name it. I mean, cardiac unit, surgical unit, operating rooms, obviously, and in wards too, right? So people who are chronic with trach tubes, tracheostomies, they do need care, right? Trach care. So they also being taken care by respiratory therapists. So what I'm trying to say is anesthesia providers being evolved, right? So it's an evolving career. And in North America, again, they have not stopped there as respiratory therapists. They built a program, a postgrad program, collaborating with anesthesiologists, and built anesthesia assistant program. In US, it's anesthesiologist assistant. In Canada, it's anesthesia assistant. I think in Europe, they are similar to anesthesia technologist role called operating department practitioners, ODPs, but they have not come this far as North America. They are still in evolving role. Same in Australia, New Zealand, they are anesthesia technicians, anesthesia technologists there. North America have come way far forward into it. So by doing the postgrad, again, you specialize in anesthesia medicine, actually. Anesthesiologists here in North America are not that many as you might see in India. So we have a lot of backlogs of surgical cases. When respiratory therapists stepped into the role of anesthesiologist, and they were like, whoa, we got some leverage here. So they were very happy to promote us, to encourage the role, and they guided us. Obviously, the same in India, the anesthesiologists are the one who's teaching anesthesia technologists and operating room technologists there. Also, faculty will be teaching, obviously, but major portion, I believe, anesthesiologist is teaching. Here, it's not different. It's the same, but we get a lot of information here. We will be getting how to manage the patient independently. Although most of the hospitals in Canada doesn't have that kind of role that I personally have in the hospital that I work. I will come for that later about that information. So what anesthesia assistants do in community hospitals is they will be helping the anesthesiologist start the case if the case is sick. And then once it's stable, they send the anesthesiologist for coffee or lunch or for epidural to start another case, whatever may be. The AAs are licensed and proficient enough to take care of the surgical list of that particular patient to finish the surgery time, emerge, extubate, and send the patient to post-anesthesia care. But obviously, in community hospitals, limitation is they always have to communicate with the anesthesiologist now and then. Okay, patient stable, going on, everything is good. Surgery is done. I'm about to extubate. I'm about to send the patient. If they are available, they come in. If they worried about the patient, they come in. If not, they say, just ping me if you need me. That's it, right? But in teaching hospitals, completely different. At least in the hospital that I'm working, this is the one off hospital where I or the A's, I should say, not I, A's, who I'm not different. I'm the A too, right? So we care from start to end, and the anesthesia staff are someone who's responsible, but they don't have to be there. So I'm able to do the pre-anesthetic assessment. I will do the medical questionnaires, pre-anesthetic questionnaires, talk to the patient, asking about the medical history, surgical history, medical problems, the medicines, medications that they take, they have stopped. So to know that, I have to know the entire system reviews, right? So we have to go in detail, in depth, so that we are not missing anything during the anesthesia time, right? We do the questionnaires. There's no question as such that it's written in. It's all day to day we do ask, so we don't have to have it in hand. We do the physical examination, chest auscultation, checking whether they have murmurs, like if they have crackles, if they are COPDs, asthma, whatever the condition may be, whether they're diabetic, hypertensive, what medication they take. So we have to go in detail whether they had surgeries before, any brain problems, any major issues that we should know, any allergies. We will be going through a system of questions. And after that, I'll make a plan whether this patient can go under general anesthesia or a deep sedation or blocks. The only limitation we have as anesthesia assistants that we won't be doing blocks. We have a block room separately where specialized in blocks anesthesia staff will be there. Nurses will be helping them. So after the block, we take the patient back if it is just a sedation. If it's a general anesthesia, we take the patient from the holding room. The nurse will get the patient. I'll set up the room, get the medications. I'll just text my consultant that this is the plan, I'm going forward. And then they can actually also see my note remotely because everything is computerized, right? So they see my note, and both of us will be in the same page. And then I start the case, and he or she might say, if you need me, let me know, right? And then once patient in, nurse will help me how to uh, do the startup. They prepare the IV lines, art lines, whatever I need, they get it ready. And when I'm intubating after induction, they will help me intubate, assist me with the tube. And once induction done, if need an outline, I'll put outline, extra lines, center lines, whatever maybe. And then once it's settled, I'll text my staff. It's a good time for coffee. So staff will come and relieve me for a coffee. And then I'll come back, and if the case is finishing, I'll finish the case, emergence, extubate, send the patient, transfer of accountability given to post-anesthesia care in the recovery room to a nurse. And every part, what I do, I make a note in the computer, sign it, and then at the end of the day or the end of the case, whatever the comfort level, convenience level for the staff, they sign it. They sign the chart, and that's it. End of care. Then move on to the next patient. They don't have to sign right at the end of it. They can sign it at the end of the day too, or the next day, as per the convenience. But I have to sign what I did so that the chart is completed for the procedures, the plan, the anesthesia care has been done. Then move on to the next patient, same story. Pre-op, intra-op, post-op, done. So I finish the list for that particular day and then go home. So the day before, I know, for example, for tomorrow, I know the list today itself. So either I see my patients today, if I have time. If not, I come home and see. If I don't have time at home, doesn't matter. I go in the morning, I check. Everything is computerized, so it's not that difficult. It's everything in one screen. Obviously, the lab values there, medical problems, surgical history, anesthesia history, either they had a difficult airway or not. So we already know before we start the case. No difference there from a staff. So we have to work like a staff, but obviously we are not staff. There's a limitation. We cannot sign the chart and close it. We can sign what we did for the patient, but the responsible anesthesiologist who's covering me. They might be covering me, another resident, another fellow. It could be PG Wi-Fi, meaning postgrad anesthesia year 5, year 4. Maybe they are teaching them to. So when I'm in the room, someone will be assigned to me. It could be a medical student, it could be a anesthesia resident, year 1, year 2, year 3. It could be an AA student, it could be a respiratory student. So every day will be different. Someday I won't have. Mondays, usually I do dedicated teaching platform called ACRM, which is Anesthesia Crisis Resource Management, where we run simulations. I go to the sim labs. We have certain simulation itineraries we actually planned for. Participants are mostly the residents and medical students in the anesthesia rotations. mostly residents, anesthesia residents. They come for simulations. I brief them what the case will be. For example, let's say lap chole, laparoscopic cholecystectomy. There will be a surgeon, there will be a trocar, there will be a patient. It's a mock room. It's not an actual live OR. It's a OR, but not a live patient. Obviously, it's a dummy patient. And there will be a gas machine, there will be IV, there will be one anesthesia provider who's standing there. Most likely, it's me there as an anesthesia provider, and then I hand over to the resident, and then I walk away. Okay, we will be seeing what they are actually doing during the crisis. So we will actually make a crisis happen. Let's say, for example, the surgeon is doing with the trocar, and suddenly they clip a artery and it's bleeding, right? So we'll make it happen. Say surgeon is yelling, I'm not able to stop bleeding. So for example, okay, we'll see how the anesthesia provider is managing the patient at the time, how they are communicating with the surgeon, what they are doing, how are they mitigating, like trying to stop rolling the stone down and making sure they are able to mitigate the crisis. So that's why it's called anesthesia crisis resource management. And then after the scene is done, whether they have done it appropriately or not, doesn't matter. Once they're done, we debrief it. We go into a room, we'll see the screen, what they have done. Obviously, it's recorded. We'll see, and then we'll talk. We'll get into their shoe, what their thought process was, and then we'll talk about it, and then explain what could have been done differently, what will be the outcome if you do in this way or that way. So we debrief it. And then, briefing, implementing, and then debriefing makes it a complete learning package for them. Yeah, that is my role on Mondays, and then Tuesdays and Wednesdays I work only 3 days in a week. Tuesdays and Wednesdays I do the list. Whoever comes into the room will be shadowing me, and that's about the day. I would call it as a day. This is what I do. This is what an AA do here in Canada. Not everyone gets into a teaching role. If they just want to be a clinician, they can. I love to teach people, so I kind of volunteered into this simulation program, and hence being in touch with teaching. A's do the list in the hospital where I work, and the consultant helps us, gives us break for coffee and lunch. In community hospital, it's quite opposite. A's help the anesthesiologist in starting sick cases, not all cases, sick cases, and then relieve them for coffee and lunch. So that is the nutshell of anesthesia assistant in here in Canada. I'm pretty sure India will be moving forward to that role in coming years. I don't know how long it might take, but it is all up to you guys. How you all push it, how you want your role to be, how you want to be recognized. Obviously, see, people here started as a manifold technician, respiratory technician, become a respiratory therapist, become an anesthesia assistant, right? So nobody gets into something that they wish to be, want to be. It's all up to the necessity. You create the need, you create the necessity. Use the leverage of shortage of anesthesiologists if there is. Use the need, and showcase your talents, skills, knowledge. It doesn't come without you stepping into it, right? It's not just the operating room. In ICU, be interested in ventilation. Show your talents, show your skills, what you can do. Read the ABGs, arterial blood gases, and make the changes. Talk to the intensivist. This patient may be, ready for breathing trials, like breathing trials before extubation. When the patient is ready for extubation is when you do a breathing trial and know that he or she is ready for extubation, right? So make the conversation, make the push. It doesn't happen. Nobody's gonna give you, hand it over. Okay, you seem to know. I assume that you probably can do this. Nobody can put that risk, right? So you have to step forward. You have to step into the role of showcasing that I am able to do it. If the organization supports you, well and good. If the organization is not supporting you, go do some publications, do some research work, and talk to people in a higher level where they can actually push the organization, right? It cannot happen with one person. A group of people can make it happen. One person might seed, another person might pour water a few months later, right? And someone will be getting the fruit or the shadows of the tree, right? So same thing. Make the change, make the skill level changes that you can showcase them, right? Obviously, when you do this, the efficiency improves in the operating rooms and in ICUs. You don't work by side. You will be working hand to hand. You will be working side by side, right? So it is not just being helping. It's like doing when they are thinking about doing it. You are one step ahead, but don't step into the shoe without communicating. You need to communicate before you do. That's very important. That's why I was saying communication is very important. I wish it's given very important part of learning when you're a student. Communicate and then showcase and get the trust, right? Anesthesiologists love people who can be their hands, their eyes, right? So collaborate with anesthesiologists. It's not just anesthesiologists, multidisciplinary, right? So you have to deal with nurses, you have to deal with surgeons, you have to deal with intensivists, you have to deal with respirologists, gastroenterologists, wherever you work. You have to collaborate with them, communicate with them, showcase your skill, what you learned, what you can do, what you can outshine, right? That's how it can evolve. It's not going to evolve. It's not going to be like, okay, this is the role for you, and I'm willing to uplift your role, and you can make this just by one person saying it. You have to do it. You have to make them think and accept you and get the trust, right? That's how the roles can be evolved. Let's move on to the next topic. That's the CPD. Well, I've said enough about increasing your knowledge level, skill level, right? So if you're done in education and you started working, many have thought, okay, I've done my studies. It's time to earn money. I'm here just to work. Let me start my day, end my day, get my pay, be with my family. Nothing wrong, right? I'm not saying, it's human nature. But if you don't put your time learning while working, I'm not talking about when you're a student. When you're a student, obviously you're pressured to learn, right? You need to learn. You have to learn. You have to, show in your exams, in your vivas that you have to explain the answers. It's not about the student I'm talking about. It's about being a professional and learning, continuous professional development. It's very important in Western countries. You have to keep yourself with the credit points. I have to keep every year minimum 25 credit points to keep my license, right? I have to either attend a conference. What are the ways to do the CPD, so the continued professional development? It's simple and easy. Read a journal. There's so many journals coming up in India, right? So Indian Journal of Anesthesia, Indian Journal of Respirology, operating room, whatever field you are in, right? European Journal, American Journal. It's very easy. Take a topic, read. Don't just read and throw the book. Write it down what you studied, what you read. Make a note, that the date of the journal, topic of the journal, what is it about? So it sticks on to you, right? Attend a conference, a webinar like this. Conference doesn't just give you information, it also give you network, right? So social networking, you'll be meeting peers, you might be meeting more than peers, you might be able to explore what you can do next in your career, right? If you are a nerd, if you are smart enough, if you're confident enough, present a topic in a conference, right? In a webinar, you go for it and try your best and do it. Obviously, you need some preparation for it. You need to be well versed about the topic. So make sure that you are good in your topic that you're talking about, right? Mentoring a student, mentoring peers, teaching students. So when you teach and mentor a student about a topic, you not only know the topic, and you also telling about the topic, and it sticks onto your brain more often than just reading it, right? How to advocate, how to expand. We talked about expanding, right? So how to expand teaching roles and mentoring future professionals. You're not the end of the professional, right? There will be more people coming after you. So make a way for them teaching the skills that you learned, um, mentor them in a way that they can be better than you, right? How to advocate. If you don't advocate, don't expect recognition, right? So if you are advocating who you are, what you are doing, the recognition might follow. Might follow. I'm not saying it will follow, it might follow, right? So you have to advocate, how to advocate, be a part of a society or an organization, right? So join the society. Pretty sure there are societies in India, like one that we have Council National Day, right? So talk about your past, current roles, and how you can evolve the scope of practice, right? The scope of practice is very important. You have to strictly adhere to the scope of practice. You cannot go beyond the scope of practice without making that in written directives, right? So you might have written medical directives for now, and if you step away from it, it might risk the patient, right? You don't want patient care issues. Strict with the scope of practice. How you can evolve the scope of practice is explaining about what you can do in future, make a directive, make proper documentation, present it, get it authorized, and then, you know, you have done most part of it, and then just following scope of practice then after. When you are in that scope of practice, don't stop there. Again, push yourself. Read the journals, talk to anesthesiologists, talk to peers, and then do the next level of scope of practice. Again, do the same. Talk, advocate yourself in the society or organization, make a plan, document it, present it, and then get it legalized, whatever the way it is. In every province, every state, every country has their own medical council, authorizing body, regulatory body, right? That's how you can evolve the scope of practice. If you're not able to get the recognition where you work, again, you have to go to the higher authority who controls the organization. Always don't stop stepping forward with excuses. Excuses can never make you, a better person. You can find million excuses, but you need only one right step, right? One right step to push forward. I think if you do that, again, sky's the limit. We are already in the conclusion now. The CAT team, Anesthesia CAT team, or the vital, strong role for safe and effective anesthesia care. We have shaped better from where we are, where we were actually in North America. I'm pretty sure this will happen in other parts, especially in India, right? Where medical care is always in need because the population is always growing, always medical care is need, and it's always in shortage. So use the need and the shortage wisely when you become a professional or you are already a professional. Push yourself, right? Remember, you cannot withstand the competition without committing, right? Without committing to a lifelong learning. You have to do your continuous professional development. You have to keep yourself updated with knowledge and skill, right? You may be again planting the seed. You may not be the one who's getting the fruit or shade, but at least you have started it, right? So by saying that, just don't fall back on not sealing your commitment. Okay, this is very important. Commitment to lifelong learning and clinical excellence is something will get you way forward in your future. You probably will be a different person. By saying that, thank you for listening to me so patiently. I hope you guys have not fallen asleep. At least my time is 1:15 a.m. now. For you, it's the morning. Thank you again. Any questions? Go for it.
So thank you, sir, for sharing your valuable insights and also for sharing your wonderful journey and vast experience with us today, sir. Your words are truly inspiring and motivating, and we are very grateful to have you on the special occasion, sir. Thank you very much once again for spending your valuable time and expertise, sir. We are grateful, sir. Thank you.
Welcome. You're welcome.